Welcome back, everybody. So we're going to chat. So I get to put on my internal medicine, emergency medicine hat now. And one of the things, if you're trained in both IM and EM, I somehow always get the topics that are very IM-ish, internal medicine oriented. So hopefully what I can do is distill it down to the things we need to know in the emergency department. So we're going to, for a half hour or so, maybe a little bit less, talk about endocrine and acid base. That's the stuff we need to know in the ER. And it's actually important. We get to do this. The thing I love about being an emergency person who had trained initially in internal medicine is that I realized that the things that I wasn't wild about in internal medicine, but that were like the ongoing things, the cool stuff I liked in internal medicine, I still get to do in the emergency room. So I still get to do the fun part of the ortho, the fun part of the endocrine. So let's talk about what the fun part of endocrine and acid base are for us. And I'm going to start with diabetes. We have so phenomenally much diabetes in the United States. It is mind-boggling. The data says that a child born today in the United States has about a 25% chance of being diabetic by the age of 20. We just are a country that has really rampant diabetes, remarkable diabetes. And we know the symptoms of diabetes. And one of the things that you as a clinician can do that shows that you're an astute clinician is to pay attention to the things we think about the polys, right? Somebody who comes in with diabetes that's out of control or new diabetes. They have the polys. They're polyuric, polydipsic. They're eating a lot, they're drinking a lot, they're peeing a lot. We think about that. But the other things you can ask about, like do your wounds that are taking a long time to heal, or especially if it's a woman, someone who's had a multiple series of yeast infections. It's like I had 3 this year. What is up with 3 yeast infections? And I have this little pannus, but under my pannus over here, under my breasts, I keep getting this skin infection. What is that? So that's a sign that they actually have diabetes. So you can actually diagnose this with these symptoms, and some of them are a little more uncommon, but you as an astute clinician can pick it up and actually check a rapid sugar you might not otherwise check in somebody who, say, has, a yeast infection of their skin. The thing that we know we worry about with diabetes, and it is sometimes the first presentation for people, is DKA. So diabetic ketoacidosis is, we're actually a little bit blasé about it, honestly, because we see so much of it and we are so good at treating it that people tend to do relatively well with DKA. But every once in a while they don't. And it's actually a metabolic derangement that is fascinating of what your body does. We need sugar. What you all just had for lunch, what your body really likes is sugar to work from. Your brain only works from sugar. That's what sort of fuels your brain is basically breaking down glucose. So it doesn't break down fats very well. Your brain doesn't use those. It uses sugar. So if your body for some reason can't mobilize its own sugar, either you have no insulin, so you're type 1 diabetic, you can't use your own sugar, you have to get your fuel from something else. And that's where it goes to break down the fats, and it causes this whole cycle of what causes a ketoacidosis. Ketones first, and then eventually a ketoacidosis. And to be sort of honest about how we do this, sometimes we will see people early DKA where they're only DK. They're diabetic, and they've gotten to sort of the ketosis stage. They're starting to break down their fats, and they haven't quite got to the acidosis stage yet. And sometimes we'll see people at that stage. Our waiting rooms, people wait long enough out there that they've clearly gone from DK to DKA while they're just sitting in the waiting room to get seen. But we can see people in that whole spectrum of the DKA spectrum, even this sort of a little early on. Now, DKA is almost always type 1 diabetics. It's an insulin lack person, somebody who has a problem they don't have enough insulin. And this may be the first time they present with diabetes is with DKA. This is usually how children with diabetes, especially pre-verbal children or children who don't communicate very clear, or whose parents don't notice that they're drinking a lot or eating a lot, sort of seem thirsty all the time. This is often how children will present first, is in DKA. That's where we'll see them. I'll talk about that problem with that in a second. Now, when you have DKA, your sugar's high, right? But I can't use it because my insulin's not working, so it's just high. I have the polys, and with the polys, I get dehydrated. So dehydration is pretty common in DKA patients. They're down usually about 2 to 5 liters, more in the 2 to 3 range. So they're dry, but they're not super, super dry. Well, that's in distinction to the hyperosmolar state we'll talk about later. When you start to get acidotic, your body doesn't like being acidotic. You have a metabolic acidosis. It's these chemicals in my body that metabolically are out of whack, causing an acidosis. My body doesn't like building up of acid. The way I get rid of it is to blow off CO2. I'm blowing off what's helping, what is a metabolite of the acid in here. I'm blowing it off. So this is that breathing I was talking about. You're doing that, Diane told me to look at the breathing while I'm counting, and I'm looking, and wow, they're taking these big, deep breaths when they breathe because they're basically blowing off CO2. It's called hyperpnea. Deeper, bigger breaths, not tachypnea, more rapid breaths. So you're looking at that breathing. They have this rapid, deep, or one or the other or both breathing. That's that Kussmaul breathing. And I'll tell you, you can tell this when you really look at it. It's like, oh, that's what it looks like. I totally see what this means. Sometimes people feel a little bit lethargic. They just don't feel very, very well. And if they keep going down the DKA path, they can go frankly into a coma. They may have some belly pain. We'll talk about that in a minute. And then what you're really going to do is when somebody comes in with DKA, there's a reason that they're in DKA. Now, if it's a kid who's their first time, their reason they're in DKA then is because they just didn't have any knowing that they even had it in the first place. When somebody is a known diabetic with DKA, one of the things in our job is not just to diagnose the DKA, but to figure out why. It's really a diabetic where everything is going beautifully. They're eating normally, they're exercising normally, they're on their usual insulin dose. Everything is hunky-dory. They're doing fine. The problem is when something gets thrown in there that gets their balance of those things mixed up, they end up in DKA. So what you really want to do is look for the eyes. I think of this as, and I go through this list, anytime somebody's in DKA, just to make sure I figured out why today did they go into DKA? What's different today? We always think about infection, and you should always think about infection. It turns out that infection triggers DKA about half the time, a little more than half the time. And it may be something as minor as a viral URI, but it may be something as dramatic as a mucor in their nose, or a perirectal abscess, or neck fash they don't know they have. You have to be vigilant to look for anything that might be an infection. Infarctions do this, so you can also have things like heart attacks or strokes do this. But the second most common cause is infraction, meaning I didn't take my insulin dose, or I had a big piece of cake at my kid's second birthday party and had a huge sugar load. Where something happened where they did something that they knew was going to throw things out of whack, and they end up with an infraction of some sort that's caused their DKA. Pregnancy can do this. I mentioned strokes already. People who use illicit drugs may go into DKA, often because they're not eating normally, they're not using their insulin appropriately. That's how they can do it. Iatrogenic, so we do it, sometimes not meaning to. So let's say you have a case of zoster, and you decide that you're going to treat that with steroids. I'm going to treat your zoster with steroids. I think that's the right thing to do. Seems to make people a little better. But I forget to ask you if you're diabetic. Because if you're diabetic, those steroids may throw your sugar totally out of whack. So sometimes it's me. Sometimes it's an iatrogenic thing. That's one of the reasons that if I'm going to use steroids for any medical condition in somebody who's diabetic, I'll go back and make sure that what I get for those steroids is worth the risk of throwing their sugar out of whack. So for instance, if I have somebody who has really bad asthma, and they needed that steroid to really break that bad asthma, they need that steroid. And I'll deal with their sugar if their sugar gets out of whack later. But if it's something where it's back pain, and steroids really aren't super strongly suggested to be really helpful, I'm not gonna do it. I'm not gonna throw their sugar out of whack. So you're gonna not be the iatrogenic on this list by being a thoughtful practitioner and not giving diabetics steroids that don't need it. And then nuance, that's what the kids tend to have. When you diagnose this, I'll tell you, if you're my husband's one of these people, if you're one of those people that smells the ketones, apparently it smells like fingernail polish, I don't know, because it's genetic. You either have the gene or you don't to smell ketones. Some people can literally walk in an ER and go, okay, where's the DKA patient? I smell it, where are they? I know that my husband can do this. He's like, he can tell, it's crazy. I wish I had that. I don't have that. So I need to do some sort of testing to figure it out. If you want to know quickly if someone's in DKA, you're gonna get a finger stick sugar, that's usually going to read critical high, and you're going to get urine and you're going to dip it. And if the urine dips for ketones and their finger stick is critically high, that's a 90+% likelihood that they have DKA. That's wonderful. Then I can go on with my labs. So that's one way to do a quick screen. So if you're in urgent care or a clinic or an office-based thing and you're just not sure how sick somebody is with their sugar that's high, check a urine, see if they have ketones or not. If you're in the ER, someplace where you can get tests done quickly, then you're going to go ahead and check finger stick and follow up with a real glucose. I'm going to check for metabolic acidosis, and that I'm going to do either by a VBG, which I don't usually need to do, or by sending labs. And we'll talk about some labs in a sec, because I'm going to look for those labs, not just for whether they have a metabolic acidosis, but whether they have a gap too. So I need to know if they have an anion gap. Remember, diabetes, this is one of the things, it's one of the things in mud piles, DKA, that causes a metabolic acidosis with an anion gap. I may be dry, so my BUN may be high, and I'll tell you, the single lab, once I'm sure it's DKA, it's, oh, your sugar's high, yeah, my single lab that I'm going to laser focus on is that potassium. I'm going to come back to that in a second. Here are the sort of things to think about. Remember, we've got all the I's that can cause somebody to have DKA, so you're not going to do everything on this list in everybody, but you're going to think about it in the right situation. You may need a chest x-ray if you think somebody has pneumonia, for instance, that's maybe causing them to be in DKA. Have tipped them over. All the EKG, if I'm worried, you're not going to get all of these in everybody, please don't. But if it's like, wow, yeah, I had a little chest pain, it was kind of pressure-like, and I haven't had it before, and now my sugar's out of whack, and oh, by the way, I'm in DKA, well, now I'm going to get that EKG. Maybe it's an MI that caused that. Get a troponin as well. So this list is not mandatory in everyone by any stretch. But you're going to use your smarts to pick what things on this are appropriate for that individual patient. Now, one of the things I'm also going to mention, and I'll mention this tomorrow, I think it's tomorrow when we talk about electrolytes, is talking about what's called the corrected serum sodium. I'm not going to spend a ton of time on this today because it's more important in the electrolyte talk, but just know that when your sugar is really high, it tends to cause a dilution of your sodium in your serum, so that their sodium goes down. And I'm going to spend a little more time explaining it when we talk about electrolytes. I'm going to flip it around. We're going to talk about hyponatremia first instead of DKA. But just know that that correlation can happen. High sugar, low sodium, high sugar, low sodium. Just kind of put that in your head, and there's a way to correct for that. That's actually, here's the formula, and I'll tell you later how that works. When you treat a DKA patient, the most important thing you can do is rehydrate. It turns out if you can fill the tank some, and remember, it's only 2 to 3 liters, you don't have to go crazy. If you fill the tank some, that person basically can pee out, now they're more hydrated, they pee out some of the sugar. It starts to fix the process anyway. So go ahead and start with normal saline. Remember, you're filling the tank. At some point, you are going to switch it to half normal saline. And again, that's where that corrected serum sodium may come in. I'm not going to get into the nuance because that's really nitty-gritty stuff. But just know that normal saline is usually only 2 to 3 liters total in a DKA person you need. How aggressively you give that as far as how fast depends on what their status is. Most of the time, an hour or 2, maybe 3 is plenty. You don't have to go faster than that. That's usually just fine. And then kids with DKA, just know that there's a lot of controversy about what you do for fluid hydration in kids with DKA. There's a wonderful paper that Nate Cooperman and his group put out looking at the risk of basically cerebral edema in children. We know that kids who are de novo DKA patients who come to the ER, they're often a little altered. It's the first time they've ever had DKA. They're often pretty sick when we see them the first time. We know that the mortality rate in that group is 1%. And it's been 1% forever. It's 1% no matter what kind of fluids you give, or you give them liberally, or you give them in kind of in a restricted fashion. It turns out that just bad DKA in a kid that's a new DKA is just a bad thing. Fluids, you basically use your clinical judgment. If you need to tank them up because they look like a little raisin, please tank them up. It turns out the fluids themselves probably are not an issue at all, and that's what Nate Cooperman's study showed. We can talk about that later if you're interested. We know that the way to truly fix this, remember it's an insulin deficient state, the way to truly fix this is to give the insulin back. But insulin drives potassium into cells. When we talk about the electrolyte talk, we're going to talk about the fact that we treat hyperkalemia by giving insulin. We drive the potassium into cells. We'll flip this around. I need to give insulin to fix DKA. It's the only way it's going to really fix itself, ultimately. But if someone's potassium is low and I give them insulin, I'm going to drive that potassium even lower. Always check the potassium first before you give any insulin in a DKA patient. Most of the time it's going to be normal or high, actually. Acidosis, if they're acidotic, drives their potassium higher. But sometimes it's not. And if you decide to just give insulin blindly, it's going to be not often, but it's about 5% of the time people are hypokalemic when you see them with DKA. So just be careful. Don't start the insulin until you actually have that potassium level back. There is, oh, by the way, but when you start the insulin, no bolus is necessary. I was taught that back in my internal medicine days. You had to bolus. Don't bolus. Don't need to. The infusion rate here is what is sort of to explain to you on the infusion rate. It's about 0.1 unit per kilo per kilo per hour. It's usually about 7 units an hour for most people. That is plenty to go ahead and treat somebody's DKA. This chart looks really scary. It's not. When you treat DKA or hyperosmolar state, please Google American Diabetic Association algorithm for DKA treatment. It's up to date. It's actually up there. It's in a lot of the apps that Martha told you about earlier. This table is important because it basically tells you the 4 modalities we have to treat DKA. You have the IV fluids, which are there on the left side of that. You have the insulin dosing and sort of when to give what kinds of doses, when to drop it, when to add sugar back, et cetera. That's in the middle. But you'll notice there it's potassium. And there are some cutoffs on potassium, 3.3 and 5.5. Look at those and again, follow this algorithm. If you follow this algorithm, you will not go wrong in treating DKA. And they have a little thing over there when to give bicarb that is highly controversial. Very, very rarely is bicarb ever given in DKA for a lot of kind of complicated but very valid reasons. Even if people have pHs as low as 6.9, you don't really need to give bicarb, even 6.8. It will fix itself when you take care of their fluids and their insulin and their potassium. So that's DKA. In the same spectrum of high sugars, there's this thing called hyperosmolar hyperglycemic state, and it's had all kinds of names over the era, but HONK is one of them, you may know it as. This basically is somebody who has usually type 2 diabetes, which is an insulin-resistant state. I have insulin, I just don't use it well. And I end up with super high sugars. Now these people get super high over time. DKA patients have an event that makes them sicker, and they usually come see you pretty quickly, day or two, even hours. These patients can go days to weeks with their sugar getting a little higher and a little higher and a little higher. They're peeing more, they're drinking more, they're peeing more, they're drinking more. But these people can end up with sugars that are 1,600, 1,800, 2,000, 2,200 is the highest one I've ever been aware of. They can get their sugars like off scale crazy. They also end up being very dehydrated. Think about that. I need to pee out. If I have a sugar of 2,200, I need to pee all the time. I'm going to be dry. I can't keep up. So these people are often anywhere between 5 and 10 liters down. These people are little tiny raisins. They end up needing fluid. And the fluid you're going to use, the rehydration is vital in these people, way more important than the insulin, which you can do eventually too. You will. But you need to give these people fluids. Normal saline is what's recommended. There is an argument to be made for using the balanced solution like Ringer's and something instead, because when I give that much normal saline, I can cause hyperchloremic acidosis by giving too much chloride. So these people start with normal saline. If you start with lactated Ringer's, that's fine. But if you're getting to sort of the 4 liter, 5 liter range to get their tank filled up, you might want to switch to the balanced solution. Now this algorithm that I just showed you for the DKA thing, it's very, very similar for hyperosmolar state. Just Google it. The only thing you're going to notice is there's only 3 columns of things here because you're not acidotic with hyperosmolar state. You're just dry and super sugary. You're not acidotic. You can go ahead and use what you have, you just don't use it very well. So there's no sort of acidosis that goes with this. So you'll notice that there's sort of, this outline is very similar. Now, if people get low blood sugar, so they get hypoglycemic, you remember your brain needs sugar. It doesn't function off fats, it functions off sugar. So this is the people that come in altered, and one of the reasons anybody who's altered or seizing, anybody, should get a rapid sugar checked. Because it's not infrequent that it's a low sugar that's causing them to be a little loopy today, or frankly comatose, frankly altered. The symptoms people get on the way down, they get a little clammy, they get a little tachycardic, they feel a little queasy, they get a little sweaty because your body's saying, whoa, 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 I need the sugar, what's happening here? So those are the symptoms that go with people hypoglycemic. And again, altered mental status of any type, I don't care if you're seizing, comatose, just a little loopy, all of those should tell you to check somebody's sugar because your brain needs sugar to function. When people are type 1 diabetics and they come in hypoglycemic, it's either they had too much insulin, they didn't have enough food, or they're burning too many calories. So it's the person who on the 1st of January decides they're going to start to exercise all the time. They're going to get into shape, but didn't factor in they need more calories to do that, or less insulin when they do that. So that's one way I'm burning more calories. The other way I burn more calories is I get an infection. So even people who are hypoglycemic, that infection can cause them to be hypoglycemic as well. So that, again, I'm more catabolic because I have an infection, and it can drop my sugar. So either way, people with type 1 diabetics can end up with a low sugar or a high sugar state from infection. Treating this, if I need to treat somebody who's hypoglycemic, is I give them sugar. If they're awake and alert, give them something with sugar. Keep something in your purse, go get the orange juice, whatever. Give them something that has sugar. If they're not and they have access, you can give D5, D5W, or D10W, D5 or D25 in kids, D10 in adults. You can give that. And then you can use basically glucagon if you need to, if there's no access. Now, what if you're treating somebody who's hypoglycemic, they're not insulin dependent, they're on non-insulin dependent diabetic, and you give them sugar, and they go from to woohoo, they're good, it's all good, they're chatty, it's wonderful, and then 20 minutes from now, or 30 minutes from now, the nurse comes back and says, they're getting a little loopy again, and I thought I'd check a sugar, it's 50 again. Like, well, that's weird. Give them some more. Okay, give them another bolus of D10. Just give them, give them some more D10, give them some D50 at this time, just give them a bolus, give them that. Cool, they're awake, alert, it's lovely. Then half an hour later, the nurse comes back and says, so weird, it's happening again. They're getting hypoglycemic again. Something's not right here, right? Something's not right here. You give somebody an insulin bolus, or actually a glucose bolus, they should keep their sugar up for longer than a half an hour. What you really want to worry about then is that person's on a sulfonylurea. What the sulfonylurea does is basically it increases insulin secretion, that's how it works. So if I am on a sulfonylurea and I've taken too much of it and I've got too much sulfonylurea, I am secreting too much of my own insulin. That's why I came in hypoglycemic in the first place. Now I take that person and I give them sugar. Well, it tells me to put out more insulin when I get sugar. So what I'm getting is this person who's already got too much insulin kind of out in the system, I'm giving them sugar that increases that insulin out in their system, and they end up with this just like this with their blood sugar. It happens over and over and over again. That's a clinical clue to you that they're probably on a sulfonylurea. And what you do then is not more sugar. What you do then is octreotide. It turns out it's an antidote for this recurrent hypoglycemic thing that happens in people who are on sulfonylureas. You don't give it up front. It's only that person that keeps dropping their sugar when you give them sugar in somebody who's a hypoglycemic patient. So just remember, octreotide sulfonylureas. And these people often need to stay. But I'm going to back that up. If somebody is like that, where they keep dropping their sugars like that, you need to keep them until their sugars are steady. If they go home and go to sleep and their sugar drops, they're going to fry their brain. So you need to keep them around. There is also a pretty good rule of thumb that if somebody's on a sulfonylurea and shows up hypoglycemic, that person should also be at least OBS for about 12 hours, maybe even 24, because those drugs last a really long time. So the sort of knee-jerk thing should be on an oral hypoglycemic, coming in hypoglycemic, that person needs to probably stay to be observed. Insulin-wise, you just have to decide, why did they get hypoglycemic? Is it anything I'm concerned about? Do I need them around? It's a little more detailed decision in somebody who's on insulin. Now, thyroid emergencies. So these are not common. These aren't common. But remember when we talked about that time mnemonic, somebody who comes in who has a fever? And in there, the M is that metabolic thing. That's this. So people who have thyroid emergencies, they can either be hyperthyroid or hypothyroid. One of the things that is the absolute vital test you need to determine which is a TSH. You need a thyroid stimulating hormone level. If I am hyperthyroid, my thyroid has gone rogue, I am hyperthyroid. It's doing its own thing without any stimulation from the brain telling it what to do. It's just gone crazy. My TSH up in my brain is going to shut off. It's like, I don't need to do anything. You guys have plenty of thyroid hormone around. I'm going to shut off. So my TSH is really low in somebody who's hyperthyroid. However, if I'm hypothyroid, I'm just not producing enough thyroid. My thyroid gland, I had Hashimoto's, and I have now my thyroid's not working anymore. So I'm not producing any thyroid hormone. Now my brain is saying, oh wait, hello down there, thyroid, would you please do something? And it's increasing the TSH level, the stimulating hormone from my brain. So high TSH is in hypothyroid patients, low TSH is in hyperthyroid patients. And that is the blood test you need to determine if somebody might have thyroid problems. You can be high or low. We mentioned that before. Hyperthyroidism we see in the emergency department a lot, actually. We see this much more commonly than I think we ever diagnose. Sometimes people come in with tachycardia that's unexplained, new onset AFib that's unexplained. They may not have the buggy eyeballs that we would like them to have. That's Graves' disease. That's not the majority of people with hyperthyroidism, but they're often tachycardic, a little bit of a tremor. Their hair may have gotten kind of, thinned out. They're hungry all the time. They're warm, all those things you learned about. We see those people. And our job really in those cases is like, wow, your TSH is low, you have hyperthyroidism, let me get you an endocrinologist and get you plugged in. You don't need to do much for that. But if that same person who's been like that now comes in febrile and altered, that's thyroid storm and that's an emergency. That you need to get under control, because if they continue like that, it's going to fry their brain. They can go into cardiovascular failure. It's a big deal. They're hypertensive, hyperthermic, tachycardic. They're often sweaty. They're altered. It is a big deal. And TSHs are really helpful. It's like, whoa, low TSH and that clinical picture, I got to step in. Now, what you do when you step in is they're often a little dehydrated, so get some fluid started, but they're also hypermetabolic, right? That thyroid hormone is hypermetabolic. They need more sugar. So you're going to use a D5 something when you do it. So D5 normal saline, D5 half is fine. But then when you think about treating hyperthyroidism, you're going to go from the periphery back to the thyroid. So I'm going to start with a beta blocker. That's going to slow my heart rate down. Great. It also turns out you get a bonus. It stops conversion of T3 to T4. So I start decreasing the hormone out in the periphery. Then, and what you use for that is usually propranolol, but any beta blocker works. There's no magic here. Then I'm going to come back to the thyroid, and I'm going to say, just chill. So you can use basically PTU as black box. We usually use methimazole, and honestly, you're not usually doing this by yourself. There's an endocrinologist on the other end of the phone guiding you on this one. So that you're going to give something like methimazole, and eventually you're going to tell the thyroid to just quit, and you're going to give iodine, which basically stops the thyroid gland completely. Hypothyroidism is the end of the spectrum, and I will tell you, hypothyroidism that causes serious problems where we see people in the emergency department is extraordinarily rare. And true myxedema coma, where they're altered because of it, most of those people have had an iatrogenic reason for their thyroid not to work. We've either cut it out because they had some sort of thyroid disease earlier, follicular cancer, for instance, maybe they had their thyroid taken out. They've been taking their meds and then they stopped. Or they have something where they've basically fried that from like I-131 therapy. We've done it to them. It's rare, it's just de novo thyroid itself. These people, there's often some stressor that takes somebody who's like the lethargic, kind of thick-tongued, thick-haired person with this, they just don't feel very energetic, that person. And then they get an infection, or it turns really cold outside, or they get put on amiodarone, and they go from this to comatose. That's usually a trigger that gets them sort of symptomatic from this thing. And again, now my TSH is really high, because again, my thyroid's not doing anything. My TSH is like, hello, do something. These people are often hypoglycemic too. They're just not metabolizing very well. And my treatment here is I need to give them something to get that more thyroid hormone. But they've been hypothyroid for a while. What happens when you're hypothyroid for a while is your adrenal glands get kind of lazy. It's like, well, you're not doing much. You're sitting on the couch like a couch potato. You're not doing much. I don't need to have a lot of adrenaline coming out of here, so I don't kick out my hormones from my adrenal glands. If I'm going to give somebody some thyroid hormone and get them revved up, I need to have them have enough hydrocortisone around to handle that stress. Remember stress response that we give hydrocortisone for? I'm going to give hydrocortisone first, and then I'm going to go ahead and take care of giving them some thyroid hormone. And I'll tell you, honestly, most of the time in the ER, you're good to go if you even recognized it in the first place and gotten the right tests. Starting the hydrocortisone is all on you, great to do. Get an endocrinologist on the phone, and they'll guide you through the rest. Before and after pictures, I love this. This poor guy and his picture on the left was hypothyroid, and look at him. Look at how slender and lovely he is once he gets his thyroid taken care of. All right, we have 2 minutes to go through acid-base disorders. I will tell you, don't freak out about acid-base disorders. You need to know 3 things when it comes to acid-base disorders. Nephrologists spend their entire careers having fun, correcting things and delta-ing things. Don't bother. What I want you to do is remember a couple simple principles. We know what acidosis is, basically low pH. Alkalosis is high pH. We know you get there either by breathing, okay, I can either decrease or increase my breathing, or I get there metabolically, like DKA. I'm producing some chemical in my body that makes me acidotic. So the process is the EMEA, so basically the EMEA is the blood measure, like EMEA, blood. That's what I'm measuring in the blood. The osis is the process. What is it that's causing this? We know that to fix a problem through my respiratory system, I can do that right now. I can basically breathe really fast right now, and I can make myself alkalotic right now. You can do it, right? Y'all did it in school when you were in grammar school, did that crazy hyperventilating thing the kids do. So that's quick. That causes shifts really fast. It takes much longer for your kidneys to adjust, to compensate, so the metabolic changes actually take a lot longer. The pH, normal pH is 3.8 to 4.2, 7.38 to 7.42. Anything outside of that is abnormal. And we can actually check a PCO2 if we need to by doing capnography, and I'll come back to that in a sec. I'm not going to mention base excess. You need 4 labs to figure out what somebody's acid-base problem is. From a VBG, so you need it to figure out acid-base. You don't need an ABG, a VBG, pH, and PCO2. From the chemistry labs, the bicarb level and a calculated anion gap. You can basically look it up now. They give you the anion gap on your lab, so just get the anion gap. So again, you can calculate it if you want to. You don't even need to do that anymore. This table is all you need for the emergency department. The first step you do is look at the pH. Am I alkalotic or alkalemic, actually, or acidemic? If I am alkalemic, if my pH is greater than 7.4, the next lab I look at is my PCO2. I go to my VBG and I look at my PCO2. If my PCO2 is high, well, that's not a respiratory problem that's causing that. That's got to be metabolic. My PCO2 is low, causing alkalosis. I'm blowing it off. So it tells me my PCO2 low, that alkalosis is respiratory. My PCO2 is high, that alkalosis is metabolic. And if I flip to the other side, if my pH is low, it's acidosis. But my PCO2 is high, that's a respiratory acidosis. Boom, done. If that PCO2 is low, I'm blowing off stuff because I've got this metabolic process. That's a metabolic acidosis. And if it's metabolic, I need to go and look at that anion gap. It's on my labs, I just look at that anion gap. If it's a positive anion gap, I have a big gap. I have a very limited differential of what could be causing this problem. This is all you need to know. If you want to get fancy, I left it for you in here. You can figure out if they're mixed disorders. Honestly, you don't have to go there. You can also figure out if the compensations are correct if you are interested. But honestly, that's not what you have to know for your job. You need to know respiratory, acidosis or not, PCO2, is it respiratory, metabolic, is there an anion gap? That's it. That's all you need to know. This is why. The things that kill you are on this list on the left-hand side. C mud piles. That list of things that causes an anion gap acidosis, those are what kill you. And those are the things that we worry the most about. You can have a non-ion gap acidosis. That tends to be just people who are having diarrhea or they have a renal tubular acidosis. That's it. I have some tables for you that are just for your reference. This one and this one are for your reference. This, if you're really into wanting to know all the nuances of compensation, I put 2 things in there for you. They're interesting if you like to sort of play puzzles, but honestly, it's not what you need to know. Here's the bottom line of what you need to know. Know that one initial little algorithm with the pretty pictures. If it's a metabolic acidosis and there's an elevated anion gap, look for the bad thing. Go to your mnemonic. If there's no elevated anion gap, they probably have diarrhea or they have a renal tubular acidosis. There's no anion gap, neither of those is life-threatening. If it's an acidosis and it's respiratory, that's usually somebody who's not ventilating enough. You fix that by helping them ventilate some more, increase their ventilation. This slide is all you need to know about the things that have to do with acid base. That's it. You're done.